We can continue with the alimentary canal, so a digestive tract, and from the pharynx, as we described for the limits, inferior limit of the pharynx, we continue in the esophagus. Okay. So the next organ of the digestive tract is the esophagus. Again, we have like a tubular organ. So we have roughly the shape of a cylindrical organ, although some restrictions, which is quite regular in its shape, although some restrictions occur during the course of the esophagus because of the relations of the esophagus. And you can already recognize some of these restrictions that are the areas to which the red arrows are pointing at. Can you see those red arrows? And those red arrows, you can see that the lumen of the organ is restricted because we have compression caused by other organs. So we have these restrictions. And since we are moving from the neck region and traversing the thorax, we are going to reach the abdominal cavity. We are dividing the esophagus in several tracts. As it moves towards through different regions towards the abdominal cavity. So we recognize the first part, the most cranial part, that is the cervical tract, the cervical part, which is located in the neck. Then it enters the thoracic cavity in the mediastinum, and precisely in the superior mediastinum, and then in the posterior mediastinum, which is a partition of the inferior mediastinum. And this is the thoracic part. Then, passing through the diaphragm, it reaches the abdominal cavity. So we also described an abdominal part, and some authors also described in the middle between the thoracic part and the abdominal part a diaphragmatic part, which is very short, and it's the part of the esophagus that is just passing through the diaphragm. Okay. So you might find this, or you might not, in the books, because some authors are describing also this as different tracts, some others are not. Okay, and this is what is depicted in this very simple scheme, where you can recognize esophagus, just traversing the neck region, then the thoracic cavity, then the diaphragm to reach the abdominal cavity. And the shortest tract, with the exception of the one that is traversing the diaphragm, is the abdominal part. And also, when the esophagus ends and reaches the stomach, its lumen enlarges and the organ enlarges. Okay, so we have an enlargement at the end of the esophagus. So it is shorter, but it is wider. And these are the restrictions that occur during the esophagus course. And these are due, as I told you, to the relations of the organ with other organs. The first restriction occurs at the junction with the pharynx. And this is due to the inferior constrictor muscle of the pharynx. We just described that. Remember the superior, the middle, the inferior, and the inferior one was the one that was originating from this oblique line on the thyroid cartilage and then on the cricoid. And that's why we recognize two parts of this muscle. One from the thyroid cartilage and the other one from the cricoid. And it's specifically the part from the cricoid that is causing such restriction at the very beginning of the esophagus. Then the esophagus has also relationship with trachea, but especially since the trachea is a little bit on the right side, and the esophagus instead is more on the left side. Okay, so when the trachea ends bifurcating into the two bronchi, since the esophagus is more on the left, it is then crossed by the left main bronchus. And maybe even yesterday we described this. You remember that the arch of the aorta just passes over the left main bronchus. And in this way, the esophagus is both in relation with the left main bronchus and the arch of the aorta. And these two organs are compressing the esophagus, thus causing a second restriction. Okay? The third one, the last one, is the one we find when the organ passes through the diaphragm. So it is at the esophageal hiatus. So these three red rectangles are to indicate the restrictions that occur during the esophagus course. So I told you it is roughly a cylindrical shape, although it is a bit flattened. So we have we can describe an anterior wall and a posterior wall and two right and left margin. It's a bit flattened. Okay, and although it is quite regular in its caliber, we can find such restrictions because of the relation that we are going to describe. So I'm going to show you this restriction. Okay. Here, the cricoid cartilage. Okay, and from the cricoid cartilage, this part of the inferior constrictor of the pharynx origins. Okay, and then it causes the first constriction, the superior constriction, or the upper constriction of the esophagus. And then we have the middle one that is at the level of the bifurcation of the trachea. So this is the T4. You remember we are between the T4 and T5. So it's a little bit lower because it is caused by the left main bronchus. So just after the trachea divided. And it is also called the thoracic constriction.
Broncho. I don't know why here it's
no, also bronchoaortic.
So
Bronchoaortic, okay, it depends on, they have several names. One name is related to the relative position. So upper, middle, and lower. Okay, either it is related to the organs. So pharyngeal, esophageal, or also cricoid constriction. And thoracic because of the location or because of the organs, so it is also called bronchoaortic constriction. You can choose the name you prefer. Of course, if you remember bronchoaortic, you also know what are the organs. The same is with cricoid constriction. And the last one is the phrenic or the lower constriction. Okay. That is, of course, at the level of the discus. Okay. And here is the inferior constrictor of the pharynx. Remember, we just described this as inserting, then as reaching one the other on the posterior wall. And here we have the cricoid. So along the oblique line, it is inserting, and then also on the cricoid. And the inferior part is the one that originates from the cricoid, and it is the one that is causing this constriction. So it is also called cricoid. Okay. And this is the lower constriction, the phrenic one, when it enters the diaphragm. And this is also important to ensure the content of the stomach to be kept in the stomach and avoiding its entering into the esophagus. And here we can also recognize the junction of the esophagus with the stomach, which occurs along a fragmented line, which is called Z-line, because of its form, because it's like zigzag line. What are the relations of the esophagus? Actually, we should already know this, because we described them. Sorry. Okay. Because we described this for the mediastinum. Actually, we described the position of the esophagus in the posterior mediastinum. And you saw I removed the heart to show the esophagus. In this reproduction, this this mannequin, I don't know how to call it properly, but it is not representing the pericardiosa. And of course, the relation with heart is not direct relation, but it is mediated by the pericardium. What are the anterior relations? Let's start from the cervical part. Okay, the cervical part also we already know the relations because we described the trachea, and we also described the trachea as in close relationship with the esophagus, with even a muscle in between, tracheoesophageal muscle, and so they are really attached. Although one is moved a little bit on the left, on the right, and the other one on the left. Okay. Also, we described this relationship because the larynx and the trachea are embraced by the thyroid gland, and the thyroid gland is made of isthmus in the middle and the two lobes on both sides, the right and the left. And the two lobes are on both sides, so they also reach the esophagus. So the esophagus anteriorly is in relation with the trachea, and laterally is in relation with the thyroid gland. And if we move laterally from the thyroid gland, we find again these vessels. These vessels, since we are below this plane, okay, are the common carotid artery and internal jugular vein, still accompanied by the vagus nerve and still enclosed in the carotid sheath. Okay. As regards the posterior relation of the esophagus in the cervical part, what do we find behind the esophagus? Yes, exactly. Here, the vertebral column. Okay, so So the vertebral column is the main posterior relation of the esophagus, although the esophagus, again, like the pharynx, is separated by the retroesophageal space, meaning the retropharyngeal space continues in the retroesophageal space. So again, we have virtual space. Okay. And also, this relationship with the vertebral column changes when the arch of the aorta continues in the descending aorta. Why is that? Because the descending aorta is forcing the esophagus to move forward. So it becomes more superficial. This means that a closer relationship with the vertebral column is taken by the descending aorta. And the esophagus is not so close to the vertebral column anymore, because in the middle we have the descending aorta. And maybe you can see that there. This is the level of the bifurcation, and now the esophagus is not so close as it was. Actually, in this scheme, not really say it properly, but here on the right anterolateral view, you can see the vertebral column. These are the bodies of the vertebrae, and this is the space occupied by intervertebral discs. Okay, and now the esophagus, which is at the since the trachea is still inside, is still here, still attaches the esophagus to the vertebral column. It is very close. But then when the arch continues in the descending aorta causes a movement of the esophagus on a more superficial plan. And the one that is closer to the vertebral column this time is the descending aorta. But we remember this by the position of the openings of the diaphragm. Because if you remember, the most anterior one was the one of the inferior vena cava, and then the one for the esophagus, and then the one for the abdominal aorta, descending aorta. And at this level becomes abdominal from the thoracic. Yes.
So this in the cervical part we have behind the vertebral column.
Yes, but also in the thoracic part,
You have the vertebral column, but
till the bifurcation of the trachea.
after the bifurcation of the trachea, the descending aorta
Yes,
occupied.
yes.
The posterior.
Actually, we still have the vertebral column, but in the middle and on the left side, more on the left side, we have the descending aorta. You can also see this here. This is the trachea, and then the bifurcation of the trachea, and the esophagus that was behind the trachea. Now it's coming forward. It is becoming more superficial. And behind, and on the left side, we have the descending aorta. What happened? When yeah, okay. Okay.
The thoracic, so the thoracic part of the esophagus
Yes.
starts from the bifurcation of the trachea.
No.
Before
It starts as we enter the
thoracic
thoracic.
vertebra.
No, the thoracic cavity.
Oh,
At the inferior limit of the C7. Okay. Okay. So, what are other important relations of the esophagus? Because we described the relations in the neck. Then we reached the mediastinum. And first, the esophagus occupies the superior mediastinum, where it is very deep in close relationship with the vertebral column. Then, in the inferior mediastinum, it lies in the posterior division of the inferior mediastinum. And already at this level, because when we move from the superior mediastinum to the inferior mediastinum, the trachea bifurcates. Once again, remember this important plan. Okay? Always the same angle, sternum or Lewis angle. Okay? And then T4, T5. And T4, T5 is also the level of the bifurcation. And this part is the one that is dividing the mediastinum, superior and inferior. So this means that when the trachea reaches the inferior mediastinum from the superior, and in the inferior is occupied the posterior division, so it is steep tape. Okay? It is no more in relation with the trachea because the trachea bifurcated. And the relation here changes from the trachea to the left main bronchus. Okay. So we have this relation with left main bronchus, but also the pulmonary arteries, okay, are originating from the pulmonary trunk. And this time, I know it's kind of confusion, but the esophagus has relation with left main bronchus, but with the right pulmonary artery. And this is because of the position of the pulmonary trunk and of the trachea, because the trachea is on the right and the pulmonary trunk is on the left of the esophagus. So when the pulmonary trunk divides, the right artery crosses the esophagus. Instead, the trachea was on the right side, and when it bifurcates, it's the left bronchus that is crossing. Is this clear?
Yes.
You just have to examine this picture because everything's there. Okay, it's like describing the position of the states on a geographical map, on a chart. Okay, you should just read the map, and you do it every day, right? With Google Maps, don't you? I do. I know you. I always like to follow my steps. So, in the on both sides, okay, the esophagus is also in the relation on the right side, okay, with medial surface of the right lung. You remember the esophagus? There was a groove left by the esophagus on the right lung, but also then on the left lung, because then it moves on the left, more on the left. Why is that? Because we're going to reach the stomach, which is on the left side of the upper part of the abdominal cavity. So it means that although we are with the esophagus already slightly moved on the left side. Okay, then, but in the lowest part, the caudal part of the esophagus is moving more on the left, and this is to reach the stomach. That is mostly, at least where it receives the esophagus, is on the left side, on the upper part of the abdominal cavity. Okay. Then also the stomach moves on the right side, but we need to find the esophageal gastroesophageal junction, okay, which is on the left side. And then the esophagus is also leaving a groove on the medial surface of the lung. So we have both groove on the upper part of the medial surface of the right lung, and then on the lower part of the medial surface of the left lung. This is because of its course. Okay. Still.
So, Prof, I didn't understand one thing, but at level T4, there is the bifurcation of trachea, no?
Sorry? It's
In the T4,
between T4 and T5.
we have the bifurcation.
Yes.
And then the esophagus may make contact with the right pulmonary artery, or in the abdominal.
No. Right pulmonary artery. Right pulmonary artery is in the thorax. So it cannot be in the abdominal. Okay.
So,
The pulmonary trunk, okay, it's the one that is dividing the two pulmonary arteries. Okay, and since it is, if we look at the pulmonary trunk, and the pulmonary trunk moves to the left, then it divides. So the result is that the right pulmonary artery is longer than the left one, because it is like the bronchi. Since the trachea is on the right side, the right bronchus is shorter than the left. In this case, we are on the left side, but we have to reach both of them. So when we have to reach the right one, we have to cover a longer distance. So it is longer. And it is crossing the esophagus. So obviously, it is in the thorax.
so it's
So
not
that's
with both.
okay.
It's contact with both,
What do you mean both? I don't understand.
right and left. Pulmonary.
Left. This is the left. Sorry. So only the right. Only the right. This is the right, and this is the left. And this is the esophagus. Can you see the left? It is not in relation with the anterior aspect of the esophagus. Okay? So the main bronchus is again the left, but the pulmonary artery is the right.
Okay.
Again, just think about the position of the trachea and the position of the pulmonary trunk.
I confused the bronchus with the.
Oh, okay. Okay. Also, below the relation with the right pulmonary artery, we find this important relation with described for the heart. So it is with the pericardial sac that is covering, enveloping in this position. Just imagine how this. Can you see this surface? This belongs to what chamber? This. What chamber is this? Just think about this.
Right. No, the left.
Left to what? Because it's not enough. We have two chambers on the right and on the left.
Left.
Left atrium. So the one that is in relation with the esophagus is mainly the left atrium. Okay. You can also lift it. And of course, covered, enveloped by the pericardial sac. Okay. Oh my God. Then, on both sides, we still have important vascular relations. Tell me.
At the level of T4, T5. Yeah.
At what? At the level of T4?
The levels where the trachea.
Yes, T45.
Does the left, what do you call it, brachiocephalic vein have any attachment to the esophagus? No?
Brachiocephalic vein?
Yeah.
No, the brachiocephalic vein is anterior. Okay, wait. Because the brachiocephalic vein, the left is this. It depends on what you consider relation. Yes. If we want to describe all the organs, okay, from the sternum to the esophagus, I'd say yes. But if we want to describe the relations, closer relations, they are not. Because the left brachiocephalic vein just crosses the branches of the arch of the aorta. And then behind, you find the trachea.
Okay.
And then behind, you find the esophagus.
Okay.
So it's
there's no
kind of far.
Okay. I thought
Okay.
someone.
It's like saying that Portugal, it's
next
close to Italy. Okay. Actually not, because there's France and there is Spain. It is the same, because there is trachea and then there are the branches of the arch of the aorta. But then there is the brachiocephalic. That's why I told you it depends, because sometimes we also describe all the organs, from the superficial one to the deep one, and that may be described as.
Okay.
So it's not in direct contact with the right pulmonary, because we have the trachea between the esophagus and the right.
We do not.
The trachea, yeah, the division.
The division
So
is
it's
not
not,
the
not
trachea.
directly in contact.
Okay, the division is not the trachea. The division is the bronchus. Okay, just now, we need to be very precise about this, because if we have a tumor, let's say tumor that is growing in a bronchus, it's very different than having a tumor in the trachea. Because the trachea means both lungs. One bronchus means one lung. Okay, so it's really something big. I know it might seem about the same, but it's not the same. Okay. It's like saying I close the aorta or I close the brachiocephalic artery.
So we have to say that the trachea.
No, I mean the bifurcation at the bifurcation of the trachea, you don't have the trachea anymore. You have the bronchus. So the bifurcation is the bronchus. What results of the bifurcation is the bronchus. It's not the trachea anymore. That is what I meant. Okay.
At 45 finished trachea.
Yes. Yes, but we know this since a month. At least this is what I thought. But on both sides, we have important vascular relations, because, and you can easily see, even here, this, can you see this vessel? Sorry. Now, just this. See a vessel? And then you see this. These are two arches. One is over the hilum of the right lung, and the other one leaves a groove on the hilum of the left lung. What are these two vessels? that are forming two arches. One is smaller on the right, the other one is bigger on the left. So, what is this? This vessel, the aorta. So, the aorta forms the arch of the aorta, which is leaving a groove on the left lung on the hilum. Now, what I'm asking is, there is another vessel that is leaving similar groove but much smaller on the hilum of the right lung. So, on the right lung. Which vessel is that? So you should think about vessel that is deep and becomes more superficial, or vice versa. So it is in the posterior mediastinum and moving over the hilum is reaching the anterior mediastinum or later mediastinum. Just think about it. What do we have in the posterior mediastinum? What vessels? You have the aorta, okay, and then something that we mentioned yesterday.
The intercostal.
No, they are too deep.
And
The intercostal are tributaries of what?
intercostal.
Vein.
Vein. No, intercostal.
I'm talking about vessel. Vessel means blood vessel. Okay, that means artery or vein.
The azygos possible.
Yes, the azygos. This is on the right side. And the azygos, you knew that? And what did you tell me?
I did.
You told me?
Yes.
I didn't hear you. No, I just realized from your face that your facial expression that you knew. But I thought that it was like the quiz that you knew, but you didn't answer. So it's the azygos that is forming this arch to reach the superior vena cava. You remember with the lung? Just when you go back home, okay, just check on the medial surface of the lungs. Unfortunately, I don't have with me the slides. Actually, I get the slides, but it takes too long to go back there. But, okay. It's better to do it now. Okay. Okay, first week.
So we have to say that the azygos.
I don't like this.
No, we have to
I don't like.
say, no.
I have to say.
We have to know. We have to know that the
Because some students ask me, "What do you want me to say?" I don't want you to say anything. You just need to describe what you see, what you know. Okay. So tell me now.
the azygos is in relation at the right. With
Yes, on the right side of
That's
the
possibly
esophagus.
to the right front, so to the right line.
No, wait, I didn't understand this.
So we have the azygos at the right of the esophagus.
Yes.
In the posterior mediastinum.
Yes, but it's
Posteriorly to
the arch of the azygos that is in relation with the
the
esophagus.
arch,
Yes, because the azygos is deeper.
Okay.
Just wait a sec.
Okay. Understood. Yes, and go parallel with the aorta and the esophagus, no? The shine parallel with the aorta and the esophagus.
Yes, but not on the right side, not on the side, but posteriorly.
To the esophagus.
Yes. I'm gonna show you. I'm gonna show you this. Okay. Okay, found the picture. You remember this? Right lung, the hilum, esophagus. You remember when I just told you and the esophagus is leaving a groove on every part of the medial surface of the right lung, and then also on the lower part of the left lung, here. So if we examine these surfaces, oh my, okay, here, this is a groove. This is which lung? Maybe it's written. I'm going to find it. Which one is this? Come on, it's easy. How many lobes? How many fissures?
The left line.
Yes.
So there is
One fissure, two lobes.
No.
One fissure, two lobes. See this? Two fissures, three lobes. Okay? So now, on the hilum here, can you see this arch? This is the arch of the aorta. And then the descending aorta. And what did we just describe as a relation between the descending aorta and the esophagus? The descending aorta is forcing the esophagus to become more superficial. And this is the esophagus. This is posterior. Here, we have the groove of the esophagus. On this side, okay, we have, again, the groove of the esophagus. And then we have this smaller arch. Can you see this?
For the
It's smaller than this. And this is exactly the azygos vein that is going to reach the superior vena cava. So if we look at this way, okay, superior vena cava and arch of the azygos. Okay. Now you can see that the azygos is posterior to the esophagus. Okay. We can say posterolateral, but still posteral. Instead, on the right, you can see this. On the right side, it is crossed by the arch, but the azygos is posterior. It's deeper
then
than the esophagus. And in fact, when here we saw the esophagus, can you see the esophagus? Esophagus. Here is the azygos.
it's not
What's cut?
completely behind the esophagus. It's just a little bit posterior, but at the right.
It's posteral lateral because it's on the right side. Okay. Wow, I thought that maybe in 1 hour we could describe the esophagus and the stomach. Okay. But do you realize now that we are just putting things together, always the same things? Because we described this for the mediastinum, for the lungs, for the trachea, for the heart, for the vessels. Right? So we are repeating, but maybe looking at them from different view. Okay? But still, it is something that is there already. We should just put things together. And this is very important, because if you study just collecting information, putting them together every time, it's easier. It's going to be easier. I told you at the beginning it's harder because you know very little about the organs and their location, their relative location. But as we go on, you know more. So we add details. Then we recall information that we already have. Okay, so that's why I told, and I wanted you to see it now. I told you when you go home, but it's better to look at them again together now. Then we know much more. We know about the aorta. We know about the superior vena cava and inferior vena cava. We know about the azygos. Now we're learning about the esophagus too. Okay. I'm going to close this and open the other one. Okay. Okay. Okay, so while on the right side, we have the azygos vein that is going to reach the superior vena cava. On the left side, again, we have the arch of the aorta. And this is because the two vessels, the azygos on the right side and the aorta on the left side, are passing over the two bronchi. The right, the azygos, and this is what should you think about the hilum of the lung, and the right hilum. And in fact, once again, these two groups were on the hilum, and at the hilum we find the bronchi. So they are passing over the two bronchi. Okay. And on the right side, you can now see the position of the azygos vein, which is deeper. And then it starts to form the arch. The arch is going to pass over the right main bronchi, and then it is going to cross the lateral aspect, the right lateral aspect of the esophagus. Okay. Again, in this picture, we remove the esophagus, and we are looking at the organs that are deeper in the posterior mediastinum. Here we find something more, because we already know about the descending thoracic aorta on the left, the azygos vein on the right, and there is something more. What is that? Thoracic duct. Yeah. Now, the esophagus has also a very important relation. We are not going to the microscope today. Okay. No, because otherwise we're not going to finish the stomach. What do you want? What do you prefer? Because if you are too tired, you look at the spleen at the microscope. If you're not, if you can stay old, we can continue this sentence. Go with the stomach, or with the stomach. Okay. You can answer in a few minutes as I finish this esophagus, because you are going to finish this esophagus anyway. Okay. So another important relation of the esophagus is with the vagus nerve. And the vagus nerve, actually we have two vagus nerves, one right and one left. And at the beginning, they descend on both sides. So, do you see these rectangles again? Okay. One is on the right vagus, so it is on the right side of the esophagus, and the other one is on the left side of the esophagus. Okay. Now, when they below the tracheal bifurcation, they start giving branches and forming the esophageal plexus. And from the esophageal plexus, then two new trunks are forming. So it means that we are not capable of following the right and left anymore, because they're from this plexus, and it's the same posteriorly. And then they have, the fibers are going to reunite again and form two trunks that this time are not right and left, but are anterior and posterior. And they are going to reach the abdominal cavity as anterior and posterior trunk.
So from the vagus we have the esophageal plexus, and then
Yes, but also these are parasympathetic fibers, the one from the vagus, but also autosympathetic fibers.
but then anterior and posterior to vagal trunk.
Yes.
The left one also the level of the aortic.
Yes, that is
There's another one.
the recurrent
Recurrent
laryngeal. Here.
But
Around
but this is only from the left vagus, no?
No, this is from both, but only from the left it is in the thorax. Because the other one is around the subclavian.
Not subclavian, yeah. But I mean this one, or inferior.
Can you
to
see
the-
this? Here?
No.
Here is the left recurrent laryngeal nerve. Okay, that is going around the subclavian artery and then going up here.
But this is the right recurrent, no?
The right,
This is the right.
the right. I said the left. Sorry. No, what I meant is that
The right is subclavian.
the right is around the subclavian, so you do not find it in the thorax.
Okay. It's only.
Because you asked me only the left in the thorax, but we have two laryngeal nerves, recurrent laryngeal nerves. One on the right and one on the left. One from the right vagus and the other one from the left vagus. But the difference is where they origin. One origins at the level of the subclavian artery, so it means in the neck. Okay? And it passes under the subclavian artery and then goes up again, because the vagus is going down.
Okay.
Instead, with the left one,
It goes under
it
the
goes
arch.
the arch of the aorta. So we are in the thorax.
Okay.
Okay, it's here.
Okay.
So this one is
This one, the left recurrent laryngeal has no relationship with the esophagus as well.
yes, actually it is going. I didn't tell you because it's kind of. So they are forming since the trachea is a bit on the right and the esophagus is a bit on the left. Okay, there is forming an angle here. It's like here.
So that is why the left recurrent laryngeal
The left,
goes through.
yes, in this angle.
So still there's another connection to the esophagus.
Yes, I didn't want to tell you, but you asked me. So I'm telling you.
No, it's not a vessel, it's a nerve.
Yes, it's a nerve.
Okay.
It's a nerve.
So in terms of vessels, it's
I didn't want to add this detail, but since you asked me, I am giving it to you.
I was
That's all.
thinking there should be
Because you
another.
asked me, so it is not in relation with esophagus, and so I had to answer yes, of course it is.
So, are
Okay.
anterolateral into the esophagus.
Or what?
The two vagus nerves.
The two buggy nerves? Why anterolateral?
They,
The two buggy nerves are on both sides.
yeah. So, are anterior to the esophagus and lateral to the esophagus. The right and the left. Anterolateral.
Okay. Since the esophagus is a bit flattened, it's very hard to say anterolateral. If I should answer it's exactly lateral, I'd say no, it's a bit anterior. But
Because
I would say anterolateral, because anterolateral, I would expect that like here.
So lateral positions. But are not so close with the esophagus. They are parallel, but not
No, they are not attached. They become here.
attached. And
Yes.
something like that.
Yeah. And you can see this also here.
The esophageal plexus stands at the bifurcation of the bronchi,
The bifurcation?
where there are the two main bronchus.
Yes.
Here
What-
starts the esophageal plexus.
Yes, below. Below. Okay. So, even here. and they start exchanging fibers. They become closer to the esophagus, the vaginals, and then they kind of fill up forming the plexus. Someone asked me if we only have parasympathetic fibers, probably you. No, and I told you we also have the sympathetic fibers, and they are joining the plexus, okay, and then distributing to the esophagus. Okay, so we have both. Okay. And actually, this probably it's a bit early for you, but we find these centers, the origin of the orthosympathetic fibers in the thoracic part of the spinal cord. Right? Thoracic part of the spinal cord. The spinal cord is passing through the vertebral canal. Okay, and then we divide it as we divide the vertebral column. Although there are some differences, but now we'll leave it for the next week. I'm going to be here. What you should know since now is that the centers, so the origin of the sympathetic fibers, is in the thoracic tract of the spinal cord. Okay, these are the segments, and we are starting from the T2, from the T6, to supply to integrate through the sympathetic fibers the esophagus. Also, in this case, there are variations among authors. There are authors that are saying from C8 to L2. There are someone says from T1 to L3. But what is important is that the entire thoracic tract, from T1 to T12, we find these centers. But sometimes, again, you can find differences. Starting from the last cervical, that is C8, not C7, as for the vertebra, and till L3 you can find on the notes. Okay. My knee is good. I can't stand anymore. That's why I sit. So, what are the vessels that are supplying blood? So, we described the position of the esophagus. Maybe when I'm just telling you about the organs, you do not realize that we follow a scheme. Okay, and where the scheme is where it is located. What is the shape? Do we divide it somehow, several parts, and then we describe the relations. Okay. Then we proceed with the vascularization and innervation, and the structure. We're not going to discuss the structure today. We're going to continue with the gross anatomy of the stomach, and then we will discuss the structure next time. Okay. So let's continue with the vascularization. Most of this you should already know. What are the arteries that are supplying blood to the esophagus? We divide the esophagus into three parts: the cervical, the thoracic, and the abdominal. In cervical, you have close relationship with trachea and also with the thyroid gland. Maybe you remember that at this level we have important vessels. Inferior thyroid artery, which is a branch of yes, a branch of the subclavian. That is the thyrocervical trunk of the first tract of the subclavian artery, cervical trunk that gives, because this is the inferior, it comes from the bottom. The one from external caudate is the superior. But we are in the inferior part of this. Actually, here you also have the superior. Okay. And sometimes we also have branches from the cervical trunk or directly from the common caudate artery that are very rare. So it's enough to remember the first one. In the thoracic we know that there are visceral branches of the descending thoracic aorta. And the number varies. So we find between 4 and 5 esophageal branches. Also, we should know about the abdominal. Because in the abdomen, I'm going to cover this. Yeah, in the abdomen, you remember, because I told you that there is an artery is actually responsible for the supply to another organ that is also supplying blood to the abdominal tract of the esophagus. What is very close to the esophagus? What is continuous with the esophagus?
Which is called
The stomach. So we should think about a branch.
So they are
Yes, okay.
gas,
Gastric, which one? Gastric.
left.
The left.
The stomach.
Left gastric trunk. You remember the one that originates from the celiac trunk?
Yes.
Celiac trunk, liver, spleen, stomach, and esophagus. Okay? Once again, we are putting things together. Some of this we already know. And again, should be easier with time. I know that we are adding information, but we are also recalling what we already know. And we follow the same route back. But I want to know about the thoracic tract. What do you think? What do we have in the thoracic cavity? Which veins? This is about the venous blood, blood drainage from the esophagus. So it's veins.
Inferior vena cava. The articles.
Inferior vena cava. Inferior vena cava just is in the abdomen. I'm talking about the thoracic tract.
Thoracic.
Because the inferior is in the abdomen, and then as it reaches the diaphragm, it pierces the diaphragm and enters the heart. So it's not probable.
The thoracic, maybe azygos, hemizygos.
Right. Of course, we have. Yes. I don't want to know. I'm just happy if you remember. So.
Depends on the side you ask. I didn't know this.
No, both. So you have accessory hemiazygos on the upper and left part. Lower and left part is hemiazygos, and on the right side you have two azygos. So we use all of that. Okay, and then of course we are going to reach the superior vena cava, but that is the end. Okay. And what about this? What about this? Where is this going?
Left gastric.
Vein?
From the
Not from where is
drain,
going.
Yes.
No,
the liver.
because
It's not so common. I mean, it is actually not the slang, but the insertion of the slang.
it's an insertion of the spleen.
Spleen. Splenic.
But it completes.
It's not helping. Sorry. Left gastric. Yes. And
Is it the one that goes above the pancreas?
now that is the splenic.
Oh,
What happens in the abdomen?
Hmm?
Which big veins we have in the abdomen?
no.
Portal vein, and it is tributary of the portal vein. Yes. Remember this now?
Yeah, both of them.
But I didn't find the right gastric vein in the urology.
You didn't find the right?
Always speak about the left, but the right.
Okay, I'm going to show you in the pictures in the left. And you have also the right that is going to reach the portal vein.
Drains in, so the left gastric drains into the.
In the portal vein, yes. Actually, part of the blood here is where we have the junction with the superior vena cava as well. Okay, but this is what we described yesterday for the varices of the esophagus. Remember? So we have here a connection between the two systems, the portal-caval anastomosis.
Speaking of that,
Yes.
when we're giving the location of accessory hemiazygos, we should say upper left, not only left.
No, actually, you remember that we have two hemiazygos. One is the hemiazygos, which is lower, and the other one that is
Okay,
accessory, that is upper.
because I know it's only on the left, and azygos is on the right.
But, yes, but we have the hemiazygos on the upper part and the accessory hemiazygos on the upper part and the hemiazygos on the lower part.
Okay, so this one should be careful when they are naming that, because hemiazygos is located, yes, on the left, but on
Yes, on the upper part. Okay. And as for the lymph drainage, we reach the paraesophageal lymph nodes. So it means that around the esophagus we have lymph nodes. Okay. That are the first station of the lymph drained by the esophagus. But also it reaches the tracheobronchial lymph nodes. And part of it. Okay. Now we can move quickly to the stomach, or you tell me. Yes, because at 5 we have to finish. That's
Solo 4:20.
yeah, maybe it's better because probably we don't have enough time for the microscope, because you remember it's kind of slow procedures. You have to go one after the other. And look at that. Okay, so we move to the stomach, and with the esophagus, with the caudal tract of the esophagus, we reach the abdominal cavity. And in the abdominal cavity, the esophagus has other relations. And in particular, it has a close relation with the liver, on which it leaves a groove. And then it opens in the stomach. Now the stomach is somehow a J-shaped, organ, and it lies in the upper and left region of the abdomen. The one we called hypochondrium, the left hypochondrium. You remember when we described the position of the spleen? Okay, we said also the stomach is there. But since it is a J shape and actually its shape changes among individuals, but also in the same individual, just according to the feeling of the organ. Okay? It depends on the content of the organ. So it might also change. But generally we have a vertical part of the stomach that lies mostly in the left hypochondrium, and then it becomes horizontal. That's why the J shape.
So the caloric
Okay.
part of the stomach.
And then, sorry?
The caloric part of the stomach is not anymore left or
No, it is in the epigastric region.
gastric region.
Yes. So with the vertical part, we are occupying the left hypochondrium, and with the horizontal part, we move to the epigastric region and occupy the epigastric region. Okay. So in the on the vertical part, it lies. It is covered by the costal margin, while in the epigastrium, it is directly related to the anterior surface of the abdomen, between the two costal margin. So it's easier to palpate. It can be palpated. It cannot while it is under the costal margin, covered by the costal margin. And it is a bit flattened. So we describe two surfaces, one anterior and one posterior. And because of its shape, we have two margins that are curved. So we call them lesser and greater curvature. Lesser curvature, it's actually the right margin, this one. And the greater curvature is actually the left margin. So right margin, the lesser curvature, and the greater curvature is the left margin. So we have two surfaces, one anterior and one posterior, since it is flattened. Okay, maybe you can also see this here. This kind of flattened. Obviously, as I told you, the shape changes according to its content. Okay, but if we consider the stomach not immediately after the meal, the abundant meal, and we can describe these two surfaces and the two margins that are both curved. One is longer, that's why it is called greater, and it's the left one. And one is shorter, which is the lesser one, and it's the right. And then we have two orifices. Two orifices that are establishing a communication with the esophagus and with the small intestine. Okay. And using these two surfaces, we can describe the relations of organs. So we describe the position and shape, and what we can recognize given that shape, meaning the surfaces and the borders, the margins, and orifices. Okay. Sometimes it is also described as a dilated part of the alimentary canal, because the esophagus is kind of cylindrical, and then the small intestine is kind of cylindrical as well. Although also the large intestine has a less regular shape than the small intestine. Now, just looking at the two surfaces on this picture, on this scheme, on the left side, you have the anterior surface. So it's an anterior view on the left. And on the right, you have a posterior. So it's like this. Anterior, okay, and posterior. So, which organs are related with are in relation with stomach? If we look at the anterior surface, okay, the liver lies on the superior part of the stomach. And since the superior part of the stomach is dome-shaped, the liver has a concave impression because of this relation. And we are talking about the left lobe of the liver. Because this sulcus on the liver, this groove, is dividing the liver in two uneven parts. Because this is bigger and this is smaller. Okay? And this is the right lobe, and this is the left lobe. So the right lobe is the one that occupies most of the right hypochondrium. That's why the liver is mostly on the right side. And then it also reaches the left hypochondrium, where it is in relationship with the stomach. So we have stomach, and then the diaphragm. That's not the problem here. Of course, here it's cut. But then we find the costal margin, and attached to the ribs and to the sternum, the diaphragm. Here the diaphragm was cut as well. So we have the phrenic surface, where the liver is not covering the organ.
It's called phrenic surface.
No. No, usually it is not. Yeah,
So
in this
it's
picture you find as a code like that.
Because it's innervated by the phrenic nerve.
No, because it is in relation with the diaphragm.
Ah.
Remember, phrenic means diaphragm. Also the nerve, phrenic, it's because of the diaphragm.
And also the phrenic
Arteries. Vessels. Okay. And again, still on the anterior surface, we are moving from the costal margin and we are reaching the epigastric region. And at the level of the epigastric region, it is directly in contact with the anterior muscular wall of the abdomen. So it means we have, of course, the peritoneum, okay, and the sheath of the rectus abdominis, couldn't find the English word, rectus abdominis, and then the muscle, and then the fossa and the skin. Okay, so it means that we can palpate. What we can palpate in the epigastric region is the anterior surface of the stomach as it moves from the costal margin to the epigastrium. Okay, and we can also see it enlarging after an abdominal meal. Okay, you can see a protrusion of the stomach. Now, if we look at the posterior surface, so the posterior relations of the stomach, actually, yeah, it's a bit harder because in the middle we have an important lesser sac, meaning an important structure formed by the peritoneum. But we are going to describe the peritoneal cavity next time. So we are not going to describe now the lesser sac, because otherwise is not going to be clear. You do not have a general view of the peritoneum. Okay, so just focus on the organs that are behind the stomach, forgetting for the moment about the peritoneum. Okay, so what do you see behind the stomach? Now that we removed the stomach, what can you actually see? Spleen, then pancreas, then spleen, pancreas. What are these? Kidney and
Surrenal glands.
suprarenal gland, and then let's see something. No, don't think about vessels. Why don't you pay attention to the muscles? The diaphragm. So we mentioned diaphragm, spleen, suprarenal gland, left kidney, left suprarenal gland, left kidney. Okay. I said already, diaphragm, pancreas. Okay, and look at these surfaces. Diaphragm. And of course, between the diaphragm and the stomach, there is the spleen. And between the diaphragm and the stomach, there are the suprarenal gland, the left one, and the left kidney, too. And then we also have in front of the kidney and going towards the spleen to reach the hilum of the spleen, the pancreas. Remember we saw this yesterday. Oh, sorry. Okay. The pancreas, it's covering the anterior surface of the kidney. Okay? It's between the kidney and the stomach. Okay? Actually, maybe we are not realizing this, but we are also now we also know something about the relations of the kidney. Because I told you the kidney and the suprarenal gland are between the stomach and the diaphragm. And I told you the kidney, the left kidney, is behind the pancreas, and the pancreas is behind the stomach. So now I know that the anterior surface of the kidney should be in relation with the stomach and with the pancreas, and posteriorly with the diaphragm. This is what I meant when I told you we are getting a lot of information, but this information are going to be recalled, because of course we have to consider that this is a whole, this is an entire structure that we are dividing in several parts just to properly describe it, more easily describe it. Okay? But we should never make the such mistake to consider it separate. Okay? Actually, sometimes also as doctors we do that. We consider, if we are cardiologists, we just look at the heart. We do not think about the kidney. Many times, this happens very often. And in fact, when our patient is a real problem, we send it to the nephrologist. Okay? Directly, not even thinking about it. Why bother? Okay? So, I can remove it again so you can play. Okay. What we don't know, what we do not know yet is about the green area. And it's also not easy to recognize it here, which is the colon mesocolic surface. actually, if we put this together again, sorry, then
See,
yes. Okay. So the column is lining the inferior and the greater curvature of the stomach. Okay, but there's also a relation with the posterior surface of the stomach, and what you can recognize here is using this surface. I thought something was going to fall. This surface is peritoneum that attaches the transverse column, that is this part, to the posterior wall.
Posterior wall?
Of the peritoneal cavity, sorry. Okay? So, this column, transverse column, is not just suspended freely in the abdominal cavity, but it is attached to the posterior wall of the peritoneal cavity. Biperitoneum.
Biperitoneum is attached to transverse column.
Transverse column to the posterior wall of the peritoneal cavity.
So,
Yes.
and the stomach and the pancreas are divided by this.
No.
So if the peritoneum,
Stomach, no, because the stomach lies on this. And in fact, if you consider this plan, okay, since we have peritoneum here, you consider this plan, this is dividing the peritoneal cavity in an upper part and a lower part.
and it's not covered the pancreas.
I'm looking for something. So let's just consider that my abdominal wall is the posterior wall of the peritoneal cavity. So I have peritoneal cavity open. Okay, now the peritoneal cavity posteriorly is covered by peritoneum. Posterior parietal peritoneum. Okay, now the posterior parietal peritoneum moves forward to embrace transverse column.
But the stomach is inside this.
No, it's on the upper surface.
I mean this way, but the stomach is not in contact with pancreas because there is this sheet of.
No, because this is covering the pancreas. Covering the pancreas is here, and insertion is on the surface of the pancreas. So the head of the pancreas, part of it is on upper part, and part is on the lower part. You can see it here. This is the body and the tail, and here you have the head of the pancreas. And the head of the pancreas part is visible, it's here. And the other part is here, below. This is a very important plan because this allows us to divide the peritoneal cavity into two parts. One that is the supramesocolic space, and the other one that is the inframesocolic space. We are going to describe this more in detail when we are going to describe the peritoneal cavity, of course. But this was just to explain this colon-mesocolic surface. What this meant the column is a colic. Oh my God, it's late. Okay.
Yeah. It's not clear.
I know that it is not clear. It cannot be very clear because we do not know enough about the peritoneum. Okay. Again, this was only to explain that. Okay? But the light green part, but you do not need to understand this now, right now. Because then we are going to describe the peritoneal cavity, and it's going to become clearer. Okay? I hope 100% clear. So now, since the stomach is a very irregular shape, how can we describe this? How can we divide the stomach if we can? And if we should, if we have to. What is the purpose of dividing the stomach? And the purpose is related to the different structure we find in several parts of the stomach. Let's think about the function of the stomach. Because I told you, we start the digestion in the oral cavity, which is mechanical, and that ends in the oral cavity. But it is also chemical, and the chemical continues here. What allows this chemical digestion are enzymes, but it is also the acid which is contained in the stomach. Now, this acid is necessary to make the digestion go on, but it may also represent a problem because we have two organs that are very close to the stomach. And if we think about what we digest, we can digest a cow, I can digest sheep, I can digest pig, right? And they are they're made exactly as we are. So they have tissues, they have cells like we do. So we might digest humans or ourselves. This means that we need protection against this acid. Because this acid, as it digests the food that I introduce in the alimentary canal, I can also digest the wall of the stomach. And I need a protection. So the stomach is as the structure that allows the digestion, but also the protection. And we do not find the same in the esophagus. We find some kind of protection in the duodenum, but it's not exactly what happens in the stomach. And in fact, peptic ulcers are most commonly found in the duodenum, more than in the stomach. Why? Because the stomach is the protection. So if I have a reduction of such protection, if the stomach cannot protect itself anymore, then I have ulcers in the stomach. Otherwise, I don't. The problem is in other organs. So the stomach is made, structured in such a way to protect the esophagus and the duodenum. What does this mean? That we have an area in the stomach that is close to this opening, okay, which is the cavia, where the secretion of the stomach is not acid. So here I do not produce acid. I am too close to the esophagus. And I don't want to raise lesion of the esophagus. This is what I meant when I told you we have different structures, because of course if I have different production, I need to have different structure, or at least different cells. The same is in the pyloric part of the stomach. So the one that is closer to the duodenum. So I have a production in the part that I call the body and the fundus of the stomach that is acid. But I have a production that in the cardia that is close to the esophagus, and in the pyloric, the pylorus, so the pyloric part of the stomach that is close to the duodenum, that is not acid. This is to protect the duodenum, and this is to protect the esophagus. So how do we find these different parts in the stomach? Okay, so it is very easy for the fundus to recognize the fundus with respect to the body, and the body with respect to the pylorus, because of its typical shape. If we follow the esophagus, we can easily see that the esophagus is inserting, is continued in the stomach, not at its upper part, uppermost part, okay, but a bit lower. So there is a part, okay, there is a region of the organ that is above the cardium, and that is what I call the fundus. Also, the left margin of the esophagus is forming an angle with the greater curvature of the stomach. Can you see this? Left margin of the esophagus and the greater curvature. Here, I have an angle. It is what I call cardial notch. So if I draw a plane or a line from the cardiac notch, an horizontal line, from the cardiac notch to the greater curvature, I just identify the fundus and I separate this from the body. Okay? And the body that is with the fundus, the vertical part of the organ, can be divided by the pylorus by another plant that is dividing the vertical part from the horizontal part. And on the lesser curvature, we can find another angle when the stomach changes its direction, because it is vertical and then horizontal. So it is forming an angle that is easily found here on the lesser curvature. And this is what we call angular incision or angular notch. Okay. Now, in this case, I can draw an oblique line from the angular incisor that is going to reach by following. We said it's oblique, so we move from the right to the left, from the upper position to a lower position, like this. Oblique means this, but means also this. That's why we move from the right to the left, from upper position to lower position, and we reach the greater curvature. And now this is the line that is dividing the body from the pylorus. Okay. Also, the pylorus at the beginning is is wider, is broader, and its lumen is greater, and then it is going to narrow. And so we first have pyloric antrum, which is like a cave. Okay, pyloric antrum, and then the pyloric canal, this restricted, follows, and it ends with pylorus, which is sphincter.
So the
Means it is a region where the musculature of the wall of the stomach is thickened, so that when it contracts, it closes the communication. And when it is relaxed, it allows the movement, the passage of the gastric content in the duodenum. Okay. Actually, we do not have an anatomical sphincter between the esophagus and the cardiac, between the esophagus and the stomach. While we do have here several structures are avoiding the gastric content to enter the esophagus. One is the position, because in the fundus we found gases. Gas that is the gastric bulla, which is keeping, since we have gas, it is keeping, making the pressure on the content, so it is keeping the content away from the cardiac. But also the diaphragm and the restriction of the esophagus and the diaphragm and the muscular bundles from the diaphragm are going to restrict this opening, acting like a kind of sphincter from the outside. Okay, so we have several structures that are contributing to this, but we do not have an actual sphincter. Okay, and this is also represented here. Okay, and what about the cardia? Because we just divided the fundus from the body, and the body from the pyloric part, and then the pyloric part in the pyloric antrum and canal, and then the pylorus sphincter. Okay. What about the cardia? The cardia is a region that is found just moving from the cardia all around, just saying about between 3 and 5 millimeters close to the cardia. Again, why this is important? First, because when we describe pathological conditions in the stomach, we refer to these regions. So we say, since it is a large organ, we say it is located in the fundus, in the body, at the level of the cardia, but also because, mainly because we have different structure, meaning we have different production of enzymes and of acid in the different parts of the stomach. Okay. Okay. I want to just show you the inner aspect of the stomach. Yes, they're going to pick that out very soon because it's almost 5, and they're right because they told us at maximum at 5. We had to finish. So the inner aspect of the stomach. Can you see this folds? These are the rugal folds of the stomach. So it means that the inner surface is not smooth, but it is the same in the esophagus. And we already already made this consideration when we compared the lumen of the esophagus with the lumen of the trachea. Yes? You remember when we described the posterior wall of the trachea, where we have the folds?
Yeah.
And those folds are for the enlargement of the esophagus, and of course the esophagus has its own folds. And the same is the stomach. This is typical of the organs that are changing their shape according to the content, that are enlarging. Another important organ is the urinary bladder. Because also the urinary bladder has different shape when it is empty or when it is full. And what allows the urinary bladder to contain such amount of urine is the presence of fold that allows a distension of the walls. Okay, so these folds, these rugal folds, are going to disappear. I mean, to become flattened. Okay, when the stomach is filling. And that's why we can see protrusion, because the stomach is enlarging, and the stomach is enlarging because the folds are flattening.
The folds, you say, is the space where we have some gas.
Yes.
This gas is the one that is putting pressure.
Yes. Imagine here,
It's
putting down.
on the body.
And in fact, we are storing the body in the lower part of the stomach. Okay, I have to stop here, fortunately. But what do you think if I send you some? Yes, some questions just to practice. Let's say I have to prepare them, so tomorrow afternoon, okay, or Sunday morning.
Is that preparation for Monday or?
But even to help you to not to understand the important information you need to remember. So what you should focus on. Okay? Then we can also, at least with the ones of you that are being here, because I don't want to waste your time. I know that it's not a waste of time, but still.